This video will demonstrate the insertion of a supraglottic airway. In this example, the combi tube. All esophageal airways require the patient to have no gag reflex. If the patient regains consciousness and begins to gag or vomit, these devices are removed immediately. Extubation of esophageal airways almost always causes vomiting or regurgitation. Consequently, suction equipment must be readily available when the device is removed. Observe standard precautions. The patient is pre-oxygenated with the provider using a basic airway maneuver and maintaining inline stabilization. The provider stops ventilations and removes all other airway adjuncts. If the patient is supine, the tongue and lower jaw are lifted upward with one hand, a chin lift. The distal end of the tube is inserted until the marker rings line up with the patient's teeth. Using the large syringe, the provider inflates the pharyngeal cuff with 100 milliliters of air and removes the syringe. The device should seat itself in the posterior pharynx just behind the hard palate. Using the small syringe, the provider inflates the distal cuff with 15 milliliters of air and removes the syringe. Typically, the balloon will be placed or inflated in the patient's esophagus. The first provider begins ventilation through the esophageal tube, generally marked with a number 1. The provider auscultates the lungs and gastric area. If auscultation of breath sounds is positive and gastric insufflation is negative, the provider continues ventilation through the esophageal tube. If auscultation of breath sounds is negative and gastric insufflation is positive, the provider immediately ventilates with a shortened tracheal tube, generally marked with a number 2, after which reauscultation of breath sounds and gastric sounds is done to confirm proper tube placement. The provider continues to ventilate the patient and initiate immediate transport to an appropriate facility.